还有2位 speaker 没有上来哦。
第一位还没有开始。The first speaker, not yet.
那也
Yeah, the first speaker, not yet. The second speaker is ready.
靖宇，你有那个
已经
第一个跟最后一个的 line 吗？
我看一下，
Antonio 有没有上来啊？
第一个我有啊。
你联络一下好了。
好，
Yeah, I
Yeah.
think the first speaker and last speaker is not here. So
Mm.
I'm not sure. Maybe if not here, maybe we can remove the second speaker to be the first.
Okay.
So 我们可以开始吗？Can we start right now? Or
Yes, please.
so can we start?
Yeah, please.
Okay. Okay. Good day, good afternoon, and good morning. Distinguished faculty members, and also the participants from joining us from across the Asia Pacific region. It's my great honor to welcome you to today's APSC Cloud Forum on Cardiovascular Disease, where we will explore the latest innovation in prediction, prevention, and therapy for atrial fibrillation. So I'm Dr. Lin Yan Zhang from Taipei in Taiwan. And co-chair with me was Dr. Yasuo Okamura from Japan. And
Yeah.
also our program chair is Dr. Professor Lin Junli from Taiwan. So as we know that atrial fibrillation is a major public health challenge affecting millions of people worldwide and significantly increase the risk for heart failure, stroke, and systemic embolization. So the landscape for atrial fibrillation measurement will evolve remarkably in recent years, from recent control therapy to antiarrhythmic medication and catheter ablation to AI-enabled EKG prediction and also the EKG screening, and also the novel stroke prevention for DOAC and LAA occluder. This approach in recent years has transformed to multidisciplinary and technology-driven base. Today, the web meeting joined together, we will invite the leading experts across the Asia Pacific region and to have a discuss the key advanced element different speech. And today we will discussion faculty will have a valuable insight into the our ECG analysis, long-term EKG recording, and strategy for personalized AF management to help us increase the management. And thank you very much. And today, I think, so I'm the Dr. Lin Yan Zhang from Taipei, Taiwan, and co-chair with me the next slide. And is Dr. Yasuo Okamura.
Yeah.
Okay, thank you very much for joining
Yes.
us.
Yeah. Thank you very much
Okay.
for inviting. Yeah.
Okay, thank you. So in before the meeting, I like to disclaim that the currently the content is it belong to the APSC and cannot be distributed without the permission for APSC. And the view or the opinion for the webinar is those with faculty member and not necessary to prevent the APSC. Okay, so the live stream content will belong to the APSC. So that is started. Okay, so we will welcome the very first speaker of today, and Dr. Jose Antonio Barista from Philippines. He is currently the staff from the Heart Institute St. Luke Medical Center in the Philippines. So he will give us a talk with the benefit and pitfall for screening for underdiagnosed atrial fibrillation for stroke prevention. The comparison among the 14-day EKG holder will be called versus AI-enabled sinus EKG prediction. Okay, Dr. Barista, are you okay?
Hello, Professor. Yes, I am doing very
Okay.
well, and I'm just about to load my slides. Thank you for waiting.
Okay. Yes, please.
Can everybody see my slides as shown?
Yeah,
Yes.
yes. Yeah, you can see.
Okay.
Okay.
Yes.
All right. Okay, thank you very much. Thank you, Professor Lin, for that kind introduction. And I would like to thank the organizing committee for inviting me to this talk. So I would just be discussing about the use of other diagnostic modalities in the diagnosis of undiagnosed atrial fibrillation for stroke prevention. So okay, so let me just play through this. Yeah, here we go. So the objectives of my discussion involve to just briefly discuss some of the diagnostic features of the following modalities as shown here on the screen and to describe the benefits and pitfalls of each modality as shown. So everybody knows that in the diagnosis of atrial fibrillation or in the screening of atrial fibrillation, we utilize various diagnostic methods such as an EKG, a 24-hour Holter, and in some cases a 2D echocardiogram in order for us to determine the risk of patients to develop AFib. Also, the use of these mechanisms or these diagnostic modalities, particularly the ECG, has been shown to be a class 1 recommendation in both the European and the American guidelines, wherein the use of these EKGs usually is given a class 1 recommendation to determine the patient's risk for atrial fibrillation. So apart from the use of the conventional EKG, the use of the Holter and the 2D echo, there are actually other screening modalities that can be utilized by the clinician in the diagnosis of atrial fibrillation among high-risk populations. And these include your 14-day Holter, your implantable loop recorder, and most recently, the use of AI-enabled ECG prediction from a sinus EKG. So we start off first with the 14-day Holter. So the 14-day Holter provides continuous EKG monitoring for a specified number of days. Gone are the days that wherein patients would come into the clinic and they would undergo your usual 24-hour or 48-hour EKG or Holter monitor with wires dangling on their chest. Nowadays, the use of a longer duration Holter monitor just requires the use of a patch for ease of application and use. So the use of this 14-day Holter monitor utilizes this patch and it is connected to a central monitoring station for real-time analysis of the patient's heart rhythm. So looking here, this is an example of a 14-day Holter report from ZOXT, wherein you can see here from this comprehensive report, the patient can actually see, or the clinician can see the ECG strips of concern, whether or not there are any detectable arrhythmias or anything that should be taken note by the clinician. Also, you can see here the heart rate trends, patient events, and any ectopies that were recorded, the descriptive findings, and the final interpretation, all of which can be used in identifying whether or not your patient has any arrhythmia, particularly AFib. So the use of 14-day Holter has been shown to be very effective in detecting atrial fibrillation better compared to a 24-hour Holter. In this study by Nagashima and colleagues, in patients wherein they utilized a 14-day Holter among patients more than 65 years old without any history of AFib, they utilize what they call as a spider flash T AFib recorder, wherein in the use of this 14-day Holter, they were able to identify AF at 6.3% better than that of a 24-hour Holter, and it was shown to be statistically significant. Furthermore, in a study wherein they simulated a 14-day Holter through the use of patients with pacemakers, they were able to identify that if patients who are quote-unquote on a 14-day Holter and an AFib is detected, especially if the AF burden is more than 6 minutes, then there is an increased risk for ischemic stroke or systemic embolism. And that should actually alert the clinician in determining whether or not it is best for the patient to be started on antiarrhythmics, especially anti-stroke medications or anticoagulants. Furthermore, in a bigger study, wherein the use of a 2-week continuous ECG monitor or a 14-day Holter monitor was used, in the Screen AF trial by Gladstone and colleagues, they utilized the 14-day Holter in patients more than or equal to 75 years old who had no history of AFib. And the use of this 14-day Holter showed that AF can be detected way better among patients who are at risk for AFib. And it has shown that it has a high relative risk, and definitely the use of this 14-day Holter is very essential in the diagnosis of AFib. So the benefits and pitfalls of the use of your 14-day Holter would include, so first, basically it's non-invasive and it is only used as a patch. So gone, again, as I mentioned, gone are the days that patients would wear dangling cords on the near their chest for a 24-hour or 48-hour Holter. And this monitor usually provides extended monitoring up to 14 days. However, since this is a patch and this is attached for 2 weeks, compliance may be an issue, and 14 days may not be enough for somebody to detect that arrhythmia which they would want to diagnose. So moving on, so we go now to the loop recorder. So this is different from the 14-day Holter, wherein this is surgically implanted for, as mentioned, longer rhythm monitoring. And this could actually last between either months or years, depending on the indication. And this is utilized in patients with less frequent symptoms of palpitations, pre-syncope or syncope, or in some cases, if you want to identify AFib in high-risk patients, then loop recorder would be the way to go. The loop recorder, as I've mentioned, is implanted minimally invasively, subcutaneously, as you can see here on the left-sided image. And this device is actually very small. It is actually only approximately 2 inches long and very thin, less than a centimeter thin. And the use of this implantable loop recorder has been proven to provide better diagnosis of AFib as compared to those who are just being monitored routinely through your EKG or pulse checking. And in the loop study, it was shown here that patients who had hypertension had a higher diagnostic yield for AFib when an ILR is implanted. And in patients who have been detected with AFib through an ILR, they were able to be initiated with oral anticoagulation better as compared to that of the control group. And in the loop study, it was identified that the use of an ILR provides a 3 times increase in AF detection and also concomitant anticoagulation. In another case wherein they utilized patients, they studied on patients who were undergoing renal dialysis. Patients who with kidney failure in hemodialysis in this mid-study underwent also an implantable loop recorder monitoring, wherein patients who underwent ILR implantation, it was shown that they were able to be detected with AF burdens of more than 6 minutes, and especially in cases without prior AF. And it was shown also that the use of ILR can actually be seen in 1/3 of patients with kidney failure who are on hemodialysis. In a bigger study, in a meta-analysis by Assad and colleagues recently published at Heart Rhythm, they were able to collate data from initially, there were originally 3 studies, so Crystal AF, Stroke AF, and their per diem study. And as I mentioned a while ago, they have now included the loop study in this meta-analysis, wherein they analyzed patients admitted for stroke but without any history of AFib. And it was shown through this forest plot as shown here that there is a significant increased risk of AF detection when a patient has an ILR implanted. And the number needed to treat if a patient has an ILR has an NNT of 7.7. On the other hand, in terms of initiation of anticoagulation, patients who have an ILR show to have a significantly increased risk of appropriate initiation of anticoagulation as compared to those who do not have an ILR. And the number needed to treat for initiation of oral anticoagulation was at 6.7. So again, going back to the benefits and pitfalls of such modality, the benefit of implantable loop recorder would include a long period of detection. Again, this can detect AFib for a duration of months or years. And this has a high detection yield since this is implanted within the patient system. And you can actually monitor this, follow up with this from time to time with your friendly electrophysiologist. However, as I mentioned, this requires surgical implantation, and putting in an implantable loop recorder comes at a higher cost. And in countries where medical costs are mostly out of pocket, the cost of an implantable loop recorder may not be justifiable in terms of cost cutting or cost saving for most patients. Now we go on to the third modality, and this is actually recent, or it may also be not new because this has been going on for several years, even before the pandemic happened. And this involves AI-enabled sinus EKG prediction. So here they would utilize sinus rhythm EKGs, and these sinus rhythm EKGs would then be fed into an algorithm wherein they would be able to detect whether or not your sinus EKG has a potential to become AFib in the future or not. So here, this is one of the pioneering studies from the Mayo Clinic, wherein the study by Atta and colleagues utilize a rapid and inexpensive point of care means in identifying patients at risk for AFib using machine learning. Okay, and what they utilized was a compilation of standard 10-second 12-lead EKGs recorded during sinus rhythm. So in this study, they utilized 1 million EKGs at the Mayo Clinic from a duration of from 1993 to 2017, and that would span a couple of decades. And after filtering out, excluding a couple of EKGs, they were left with more than 500,000 EKGs, wherein these sinus EKGs were then analyzed and thrown into what we call as a convoluted neural network. Here, this is how they utilized the EKGs. So a window of interest was defined for each patient, wherein if the patient had one EKG with an AFib, they would usually document the window of interest 31 days before the AFib episode. And in patients without any AFib from their EKG, the index EKG was marked as the date of the first available EKG. And as I mentioned, these EKGs were fed into a neural network, wherein this neural network would then train the EKGs would then train the model to determine whether or not there is a risk for AFib in this case. So in this study, it was shown that the use of an AI model on the first sinus EKG had a very good area under the curve characteristic. So it means that the diagnostic accuracy of this diagnostic modality is actually very good, especially if you utilize all sinus EKGs within the first 31 days from the study start date. And it was concluded in this pioneering study, one of these pioneering studies, that the use of AI-enabled EKG during sinus rhythm may permit the identification of individuals who are at a high risk for atrial fibrillation. In another study, published at Europace in 2023, this also utilized the use of an AI-based network. And this is actually a compilation of 3 prior studies wherein they utilized these EKGs from these different studies. And as shown here in the study by Hydrell and colleagues, here you can see that they utilized 30-second EKGs from different patient groups. But you would notice at the age from between stroke stop 1 and 2 that the age difference is not that great. And as shown here, you can see that they were able to utilize 500,000 EKGs for training, and they utilized almost 20,000 of which for that. And here you can see that in the use of this AI model, there is a higher sensitivity but lesser specificity, leading to more false positives at higher sensitivity levels. And as compared to the previous study, the area under the curve characteristic was relatively lower. But again, you have to consider that they only utilized a shorter age range for this, because in the safer study, wherein there was a greater age range, the AUC curve was actually way better as compared to the 2 prior studies. And the ability to predict AF from a random EKG using the safer feasibility study was way higher as compared to that of the 2 stroke stop studies. And not only do we use a convoluted neural network or the EKG only in determining the patient's risk for AFib, we can also use other demographic features of patients who are at risk for AFib. In this study from my mentors at Taipei Veterans General Hospital, they utilized a deep learning model using not only the EKG, but the patient's clinical data. And they utilized color transformation in determining whether the patient has a risk for developing AFib or not. And instead of a convoluted neural network, they utilize what they call as a dual input mixed neural network, wherein ECG images with demographic data were used in this case. So here you can see that ECG was categorized based on the CHA2DS2-VASc score and other comorbidities. And this ECG was then processed through the AI model, and eventually a determination or prediction of risk for AF or non-AF was then determined based on the color scheme as shown here. And using this DMNN as compared to the convoluted neural network, this showed way better accuracy, sensitivity, specificity, F1 score, and area under the curve characteristic as compared to the baseline CNN model. And through this Kaplan-Meier curve, you can see that high-risk AI predicted AF using the DMNN model had a higher CV mortality and all-cause mortality. Hence, if this model is utilized to detect AFib in patients who are at risk, then if treating them early is the necessity, then it would be indicated to start treatment early, given this Kaplan-Meier curve. So furthermore, the benefit of the use of an AI screening model, it is non-invasive and allows for early risk stratification. And lastly, however, this is only predictive and has variable accuracy. So comparing the three, the 14-day Holter is a balance between invasiveness and monitoring lengths, but this may miss episodes of AFib occurring outside the monitoring period. On the other hand, your implantable loop recorder has the highest detection rate, best for infrequent AF episodes, but it is invasive and it is very costly. Lastly, your AI model, your AI-based ECG screening, is a proactive tool in determining AF risk even before episodes can occur. However, the use of this should not only be reliant on that AI generation alone. Also, we should also be complemented with confirmatory monitoring to determine its effectiveness. So in conclusion, integrating these diagnostic modalities usually offers a comprehensive approach to AF detection and stroke prevention. And AI-enabled ECG analysis can identify high-risk individuals who may benefit from further monitoring with the other two modalities as I mentioned. And lastly, above everything else, a personalized assessment and shared decision-making are essential to optimize outcomes for patients who are at risk for AFib. And with that, I thank you for your kind attention, and I thank all those who have supported us in this endeavor. Thank you.
Okay, thank you very much, Dr. Jose Antonio Barista. Yeah, thank you very nice and comprehensive talk with regarding the EKG coding and EF screening. Thank you. Right now, the session is open for discussion. Okay. So maybe time is limited. May I ask a short question? Do you see currently there are more and more reliability of AI-enabled ECG detection? Do you think that currently how to apply into integration for AI detection into the routine clinical practice? This is possible, or we still need to have a ECG confirmation for the treatment for atrial fibrillation?
So thank you for the kind question, Professor. Actually, the use of AI models in AF diagnosis is actually a new and budding modality. And since this is relatively new, definitely you would need confirmatory studies to determine whether or not the patient has a risk for AFib. The use of AI models is very useful and it is very innovative. However, still, although this is still in its infancy stage and a lot of studies are still needed, definitely in order for us to be more confident with the use of AI models, definitely we would need to do further or confirmatory screening tests to determine the efficacy of AI.
Okay, thank you very much. So any questions?
Yeah, just I want to ask you one question. thank you for your great presentation. And I want to ask one simple question about the AF burden. So in a clinical practice, what kind of situation happened as the indication for the anticoagulant AF regarding the AF burden? How 24 hours or 6 hours more, or if you see the AF detection indication
Well,
for the
in
anticoagulation. So
Okay, thank you for that kind question.
yeah,
Regarding the initiation for anticoagulation,
yeah.
if patients actually have were detected with AFib, before I even consider in my practice, before I even consider starting the patient on anticoagulant, I would actually look at the patient's risk factors, because the risk factors would actually be a very good guide whether or not the patient would need long-term anticoagulation, because there may be patients who do not have any comorbidities, but on detection screening, they were able to be detected with AFib. However, if you're going to look especially at their CHA2DS2-VAS score, if they do not fit the bill, then it is a very big question mark whether or not you would want to start them on an anticoagulant despite AF detection. So it really depends on a case-to-case basis whether or not the patient has strong risk factors for stroke based on the AF screening and the comorbidities, whether in terms of whether or not you would immediately start anticoagulation or not.
Okay, thank you very much.
Okay, thank you. Finally, thank you very much for your nice talk. Right now, we move to the second talk.
Yeah, I also introduced the second speaker, and the second speaker is Dr. Saeed Hasib Raza from Pakistan, assistant professor of cardiac electrophysiology, Muntan Institute Cardiology, Muntan Physical. He'll talk about the early rhythm control strategy, prevail rate control in early atrial fibrillation management, research of the antiarrhythmic drug after the East AFnet 4 trial. Let's get started. Go ahead, please.
Can you see my slides?
Yes, we can see the.
And I am clear. Everyone can hear me.
Okay.
Great. Thank you so much for having me here. So the topic given to me is basically focused on a trial, which is a very important trial called the East AFib net trial. So before going into the trial and discussing a few essential points which can be helpful in our clinical practice as well, there are a few introductory slides, and I will go through them quickly, and then we'll move towards the trial. So this diagram is actually from the JAC, and this is showing the current prevalence of atrial fibrillation among the adults in United States. About 3.89% is the recent data. And at the bottom, you can see what are the variables which are associated with increased risk of having atrial fibrillation, prolongation of life, male sex, and tobacco use and other family history. We know all these things. So we have this understanding that the atrial fibrillation is one of the most prevalent worldwide arrhythmia right now, and it has increased mortality and as well as increased morbidity. So this is a famous trial, AFib trial done in 2002, and this trial led to many things in the management of atrial fibrillation in the patients for the last almost 2 decades. And what this trial showed, they compared the rate control strategy versus the rhythm control strategy in patients with atrial fibrillation, and what it showed that was the primary endpoint was lower in the rate control group as compared to the rhythm control, and they concluded that there is no difference between the rhythm and rate control strategy, and you can go for the rate control strategy for your patients rather running behind maintaining sinus rhythm. Here are the primary endpoints, and you can as it is highlighted here, you can see if I can see, yeah, 310 versus 350. So definitely this showed that non-inferior. And this is another trial which was also done in 2002, another very famous landmark trials. Again, atrial fibrillation patients, rate versus rhythm control, and same results, almost same result that showed, and they compiled that rate control is almost as effective as rhythm control strategy in getting your endpoints, in reducing the heart failure and in reducing the incidence of thromboembolic complications like stroke. So everyone is using these trials, and we are getting benefit from the rate control strategy. But the idea is this. So we know that AFib begets AFib. So whenever there is an episode of atrial fibrillation, something is going to happen to the atria. And with the passage of time, these AFib episodes are going to induce some damage into the atrium, which we can call atrial cardiopathy or AFib-induced structural remodeling. And as you go from the early stages to the advanced stages, the chances of maintaining the and restoring the sinus rhythm becomes poorer. So what if we start the rhythm control strategy early in the earlier days or earlier weeks or earlier months of getting the first episodes of atrial fibrillation? So this is the idea, and this led to the again the investigators thought that it has been 2 decades, so why not we try again and let's do a rate versus rhythm control comparison randomized trial. So this was done by the German Atrial Fibrillation Network in a collaboration with the ARA. This was a randomized parallel group blinded endpoint assessment trial, which is a prospective from 2011 to 2020. And they had a handsome amount of the patients in the pool, 2,789 patients across Europe from different 135 sites. And the hypothesis was that an early structured rhythm control therapy based on antiarrhythmic drugs and catheter ablation can prevent the atrial fibrillation related complications like stroke in patients with AFib when compared to the usual care. By usual care, they mean the rate control strategy by using the anticoagulation and the rate limiting drugs. So this was the inclusion criteria and the exclusion criteria. I want you to take a look at especially at the inclusion criteria, and the patients that they included in the inclusion criteria. These are almost the same patients that we get to see in our clinics actually. So it is very interesting that whatever are the results of this trial, we can definitely use those results and manage our patients. You have age more than 65 years, you have female patients, you have hypertension, you have diabetes. So all the parameters, all the variables that we are used to see in our clinics, in our labs. And this was the study arm. This was the design that they are going to randomize these patients of atrial fibrillation who are in early atrial fibrillation, and by early atrial fibrillation means less than 1 year, paroxysmal or early persistent atrial fibrillation. And they're going to divide into two groups. The one is the usual care group, that is they are going to follow the guidelines, European guidelines, and they are going to focus primarily on the rate control. For the rate control, they can use the rate limiting drugs, and if needed, they can use the rate controlling aspect of the antiarrhythmic drugs as well. And the other is the purely rhythm control strategy. And in the rhythm control strategy, it depends on the sites and whether they are going to first use the antiarrhythmic drug therapy or they are going for the catheter ablation, cardioversion, whatever they feel appropriate for their patients. So the endpoints, the primary endpoints were the composite of death from the serious causes, the stroke, hospitalization with ACS or heart failure, the number of nights spent in the hospital per year, and the secondary were each component of primary outcome was compared about the symptoms, the quality of life, the alveolar function, and the safety outcomes regarding the composite of death, stroke, and the rhythm control therapy, the drugs that have you used, what are the adverse events. Regarding the follow-up, so at the baseline, they used to take the history from the patients. The clinical characteristics of each patient was documented. Quality of life maintaining questionnaires were distributed and they were documented. And the ARA symptom scale was used at the baseline and afterwards also. And at the 6th month, they used to send email to all these patients and they asked them about the quality of life. They asked them about any hospitalization or any cardiovascular event if yes or no, if they developed or not. At 1 and 2 year, they call the patient in the hospital, in the clinic, 1-to-1 in-person interview, document the physical examination, and see whether the patient is in sinus rhythm or atrial fibrillation right now. And every 2 year, question about the quality of life, and they document the echocardiography and the sizes and the LV dysfunctions, etc. So these are the distribution. So 2810 patients were, sorry, 1395 patients in the algorithm control group and 1394, so equally randomized. And in the rhythm control strategy at the starting, this is a distribution of the antiarrhythmic drugs that were used. For example, this green color, dark green color, almost 36% of the patients were using were put on flecainide, 7% were on propafenone, and almost 20% of the patients were taking amiodarone and dronedarone, and 8% of the patients were put on the ablation therapy for atrial fibrillation. And at 2 years, still patients were taking antiarrhythmic drugs, and 20% also went through atrial fibrillation ablation therapy. And if you move towards the rate control strategy, of course, there were minimal patients at the starting who were put on antiarrhythmic drugs, but at 2 years, a few antiarrhythmic drugs were used just to have the rate controlling aspect of the AADs. So regarding the baseline characteristics of these patients, actually between the two groups, the baseline characteristics were almost similar, except if you look at the beta blocker and digoxin. And I would like to highlight it as well that in the rhythm group, 46 patients were taking as compared to the rate control. And we know, of course, we have to use a rate controlling drugs in the rate control group more. So that's why this is the disparity. Otherwise, almost clinical characteristics are same. And the most important thing, the outcomes. So the first primary outcome in the early rhythm control strategy, lesser events were found as compared to the usual care. There's a clear difference, 249 versus 316, which was not found in race trial, which was not found in FM trial, and this is amazing. The second thing that I want to highlight in this table is the secondary primary outcome, that how much nights were spent in the hospital per year. Now, if you look here, the patients who were adopted for the early rhythm control, 5.8 plus minus, and the usual care is 5.1, almost similar. Now, this is reassuring for us actually, because in the previous trials it was shown that the patients who were put on the antiarrhythmic therapies or a rhythm control strategy, they were found to have more nights spent in the hospitals. But this is reassuring because it is now almost there is almost no difference there. This is very nice. And if you look at the stroke for the early rhythm control, 40 versus 62, hospitalization with worsening of heart failure, 139 versus 169 patients, and hospitalization with ACS, 53 versus 65. Very nice results as compared to the previous landmark trials. Now, regarding the safety outcomes, I want you to focus on the rate in the early rhythm control on the stroke, 40 versus 62. That's 138 versus 64. This is amazing. And as you know, we are using antiarrhythmic drugs, and every antiarrhythmic drug has its side effect profile. So the serious adverse event of special interest, which are related to purely the drugs related to the rhythm control therapy, were found to be more as compared to the usual care, because we did not use more antiarrhythmic drugs in the rate control strategy group of the patients. So this is understandable. The primary outcomes lesser in the rhythm control, stroke is lesser. The night spent per year, it is almost similar. So all these things are different and almost opposite, which we have been believing for the last almost 2 decades, which are showed in the race trial and the FM trial. So the rhythm control therapy initiated soon after diagnosis of atrial fibrillation reduces cardiovascular complications without increasing time spent in hospital and without any safety concerns. Now, this is amazing for patients and for the general cardiologist, and of course for the EP guys as well, to reinforce the strategy of rhythm control for their AFib patients. Now, I want to highlight a few things why this happened, why this is a big change if we compare FM trial and RAISE trial and RAISE-2 trial with this East AFib net trial. Number one thing, if you compare the both trials, you will realize that in the previous trials they tend to choose the atrial fibrillation patients who were in the late persistent stage or permanent atrial fibrillation. And the idea is, if you are going to choose the patients in the earliest stages of atrial fibrillation, this can make a difference. And this trial is showing that it has already made a difference. Number one. Number two, again, early AFib versus post AFib, because as the AFib progresses, you are going to change the atrial structure. There will be more fibrosis, and it will be very, number one, it will be difficult to restore the sinus rhythm, and then it will be difficult to maintain the sinus rhythm in the long term as well. There will be recurrence. Another thing, at that time, dronedrone was not available. Majority of the antiarrhythmic drugs which were used in the RAISE and FM trial were the amiodarone, were the sotalol, and we know both these drugs are famous for their side effect profiles. So new, safer antiarrhythmic drugs were not used in the previous trials, and they were used in these trials. Like flecainide was used up to almost 50% of the patients in the control. So if you know the judicious use of the antiarrhythmic drugs, if you know, you can get benefit from these drugs as well. Of course, 8% of the patients they were used for the maintaining the atrial fibrillation to sinus rhythm, and there was no role of ablation in FM trial, in RAISE trials. So then, of course, there's going to be a clear difference between the results. I think actually this is one of the limitation of this study, that you cannot compare the antiarrhythmic drugs efficacy versus the atrial fibrillation efficacy. The trial was designed just to go through the previous challenge of rate control strategy versus rhythm control strategy. So they have done that work, and they have come up with a result that if you are going to target atrial fibrillation in the early stage, you are going to have good results. But only 8% of the patients underwent atrial fibrillation ablation, and rest of the patients were going for antiarrhythmic drug therapy. So of course, one can get this idea that antiarrhythmic drug therapy are more good or more effective as compared to ablation, but this is one of the limitation. And we know in 2025 there are many trials and new technologies and pulse therapies are going on. So where are we heading? And of course, the cost effectiveness, the cost for the AFib ablation procedure and cost of any antiarrhythmic drug using for 1 month, this makes a huge difference when you are going to make a decision. So with this, I will conclude my talk, and I will be very happy to answer any question if there is anyone. Thank you.
Thank you very much. Yeah, you you talked also in detail of the AF and the East AFnet trial. Yeah, I understand that. Yeah, you already did have a lot of discussion about that. Do you have any discussion, question, or?
Actually, I want to, if there's any question, I have one point that I want to mention here, and actually I want to discuss with everyone.
Yeah, I want to ask you one question that in clinical and the new diagnosed AF, the new onset of AF patient is sometimes half of the patient is experience no AF recurrence in the about 5 years, but the remaining the half of the patient is so soon after the recurrence the AF. So in clinically and the newly onset of the AF it's very difficult to to do what to do that in the. But I think the most of the physicians so initiate the anticoagulant, but I'm not sure that so we should so take receive the so anti-arrhythmic drug or not. What do you think of that in the based on the so the Eastern FD4 trial? So we should so strongly recommend in the anti-arrhythmic drug even in the so first newly onset the newly diagnosed AF. What do you think of?
So clinically speaking,
Yeah.
practically speaking, when we are sitting in our clinical practice in our hospitals, when the patient comes to you with a ECG referred from emergency, that patient presented with atrial fibrillation. First of all, we do not know how many episodes he had been in the last few years. This is the first time he has come to present in the emergency or come to you in the outdoor clinic. Uh, the, Here comes the concept of the symptomatic atrial fibrillation and the asymptomatic atrial fibrillation. I personally believe when the patient is coming to you, this is not his first time actually. He has been having atrial fibrillation episodes, but those were not documented. Those were asymptomatic, or even those were symptomatic. The patient was not taking them seriously. Oh, yes, I'm having palpitations. It may be some gastric trouble or something like that. It's okay. So the duration is lesser. He is not seeking hospital care. He does not present to the hospital. He does not present to you. So that AFib is missed away. Suppose the patient is hypertensive, the patient is diabetic, age is more than 65, the shared VASC is 3, and the patient is having asymptomatic atrial fibrillation. The patient should be on anticoagulation according to the guidelines. But for 2 years, he is not taking any anticoagulant. And it is possible the patient may present to you first time with symptomatic atrial fibrillation with stroke. So now you know the patient is stroke and the underlying cause is atrial fibrillation. If you ask the patient will say, I have been okay throughout my life. This has been the first time that I am getting this thing and I don't know what has happened. And this comes back to our first talk, how to screen such patients. You have to increase your screening abilities if you want to scoop these patients out of this. It is like an iceberg phenomena. There is so much atrial fibrillation in the world and we are not able to diagnose it. So practically speaking, when the patient comes to me, I think it is his first episode. I try to dig out some history. Maybe he is educative person. He can tell me something and I can take some clues, but practically speaking it is very difficult. So patient comes to me, what is the current status, what is the chat vest, the other profiles, diabetic, hypertensive, the age of the patient, and I deal the patient accordingly. Now the second point that I want to highlight in your regard is we are in 2025, but not everywhere we are going to find a very dedicated atrial fibrillation ablation EP lab. We cannot offer every person ablation. This is a practical thing. So whether you like it or you do not like it, you have to start with antiarrhythmic drug therapy. Whether you like it or you do not like it, you have to start with sometimes amiodarone. Even it is one of the most toxic, notorious drugs in the world that you should avoid amiodarone. But if the patient has everywhere, every person is getting myocardial perfusion scan, and you are going to able you will be able to find a few perfusion defects. CT coronary angiography, mild non-obstructive coronary artery disease, you're going to find it. Now flecainide is out of the option because according to the guidelines you cannot use these drugs. So these anti-arrhythmic drugs like even amiodarone, which is uh, famous for being toxic, you have to use these drugs, number one, either as a destination therapy or as a bridge therapy till you refer the patient to the nearby EP center. The patient is willing for the ablation and makes up his mind there. So, practically speaking, I always start anti-arrhythmic therapy. I consult the patient, I tell him about the risks and benefits of the atrial fibrillation ablation. I look at the patient's socio-economic status as well, because the cost effectiveness is very important. There are many variables to, practically speaking, there are many variables to decide. But antiarrhythmic drugs in 2025 are still very handy, and we should not underestimate their power, I personally think.
Okay. Okay. Thank you very much. Yeah. Let times go over. So let's move to the next speaker. Thank you. Thank you for
Okay,
having so
thank you.
nice presentation and discussion. Thank you.
Thank you.
Thank you. And I'm Dr. Lin Yan-Zhang. So let me introduce the next speaker. So the next speaker will be Professor Tajapong Amulo from Thailand. So he is previous the president of APHIS and also currently is the director for cardiovascular metabolic center and hospital, Metabolic University, Bangkok, Thailand. Today he will give us a talk of innovation catheter ablation technology for effective PVI in paroxysmal atrial fibrillation, thermal ablation versus pulse field ablation. Let us welcome Professor Tajapong, please. Thank you.
Hi, YJ, how are you? Yasuo, how are you?
Yeah.
Hi, everyone. Good to see everyone again. Too bad I'm going to miss the real meeting in April. But okay, thank you for the invitation. Love to join everyone here again. So let me start. I'm assigned to talk about thermal versus pulse field ablation. So these are my disclosure. You just want to read the last line and that will be good enough. Now, so
I'm not able to see I'm not able to see the presentation actually. Can you check again? Because can everyone see
share the
the
slide?
presentation?
Yeah.
No slide. No.
No slide. Yeah.
No.
Yeah, no slide. Wait, one moment. Let me do it again.
Yeah.
Yeah, sorry,
Thank
can
you.
you share the slide?
Okay. Can everyone see now? Let me see. Good.
No
Does
yet.
it work?
No, not yet.
No.
No, not yet.
No, not yet.
Wait, we did it before. One moment. Play. Good, no?
No.
Wait, one moment. Do it again. So, wait, it say share screen. Let me stop the ads one. Okay.
Yeah,
Start
we only see your
broadcast.
face.
Oh, well, that's good enough. Let's see. Start broadcast. Okay, now I go to my slide. Does it work now? Good.
Oh, yes, good.
Okay.
Okay, thank you.
Okay, all right. So, catheter ablation, it is good. There's no question about it. Even a sham study was performed in England, and as you can see here, the sham study, they did everything except the transeptal ablation. They do the TE, they do the sedation, they do the pacing of the diaphragm, and you can see that AF burden significantly decreased in this group of patients compared to sham. People will say sham also have reduction in their AF burden, but nowadays, if you recall, AF doesn't only treating with anticoagulation, ablation, or antiarrhythmic drugs. There's also weight loss, exercise, alcohol, sleep apnea and stuff like that. So AF burden decrease. Why is that? People who are not familiar in the EP world might do not understand why we're concerned about AF burden. AF burden is, basically the amount of time you're in AFib. There's many, right now, we don't think we have a good consensus on how do we do that, but it's, the percentage of the time that we monitor the patient. So if he's not monitored, then we don't know. So now, but AF burden is actually predictive of an event. Even without anticoagulation or on anticoagulation, the risk of stroke further decrease, even if you're taking anticoagulation. As you can see here, when the burden goes down, the stroke and mortality also goes down as well. Again, quality of life, memories, and all those things, it goes down. Especially better with catheter ablation. The amount of AFib patients have is much lower. As you can see here, the AF burden is better predictive of mortality and heart failure hospitalization when compared to even ejection fraction. And that number was 5%. Now, okay, so you just heard Dr. Raza talk about it, early ablation, antiarrhythmic drugs is good. As you can see here, this is early rhythm control in many trials, as you have heard. The mortality rate is better. The cardiovascular mortality is also better when you do early rhythm control. So no doubt about it, stroke decrease, heart failure also decrease. So what is early? Early is, maybe a year in this trial, or people may say 3 years, but I think 3 years it means that after 3 years, don't think about it, it's probably too late. That's why it's so bad after 3 years. Now, this trial is from Australia, Professor Kalman. So having said that, earlier is better, but even, doing it right away in the early group compared to the one that wait about a year, pretty much the AF-free survival, the burden is similarly not significantly different between the two groups. Both have good reduction of their AF burden. Either early days or just wait 12 months, good. So now, it's also slow progression. When you do ablation early, even with radiofrequency ablation or compared to antiarrhythmic drugs, not just rate control, this is compared to antiarrhythmic drugs. There's, much less likely for the patient to develop persistent AF from paroxysmal AFib. So basically, ablation is good. Even in early AF, when you do AF ablation with cryoballoon as a first-line therapy, there's significant reduction, from 7 to like almost 2%, from 8 to 2% of the patient not progressing to persistent AFib. So, nowadays, in 2025, if you don't know what PFA or you haven't heard about PFA, you might miss the, fashionable train a little bit. So let me tell you about it. So I guess you should learn a little bit about the previous ablation, what we have been doing for years, the thermal ablation, radio frequency. In the old days, this was a study where they do DC ablation of the AV node, Professor Scheiman, Moradi, Dr. Gallagher, Swenson. So they ablate the AV node with the DC shock. It's hard to control what happened. It's painful, but the AV block happens. So, many years ago, this is like, 40 years ago, Professor Wang did introduce the RF ablation as a source of ablating the heart muscle. The difference between the resistance between the heart muscle and the electrodes increased temperature at the area where the electrode touches the heart and kills the cells. Basically, that's easy to understand. Now, usually it's not dangerous. It doesn't have the unpleasant side effects like when you DC ablate the patient. The lesions are well circumscribed, definable lesions, easy to control how big, how much energy, how much temperature you want to do. It could be doing by, again, power control, temperature control. And nowadays, with the irrigated tip, it's decreased charring and boiling and sticking to the heart. So, it's been safe. It's been used for many years now. And it's highly effective. It does have some limitations. It caused the endothelial disruption, which means it's coagulable state. The underlying tissue is also destroyed. Increased thrombus formation. It can pop, which cause barotrauma, cause perforation of the heart. It could cause pain, and certainly, yes, different places it could be causing AV block. Now, the effective lesions for RF ablation, it depends on the power, depends on duration of the ablation, the contact, the stability of the catheter, the tip temperature, the tissue itself, impedance reduction, electrogram attenuation. You would want to see all these to see that the lesion is getting good and you get good effective lesion, not just hitting some red blood cells. Now, so that's the thermal hot ablation, if you call. Now it's the cryoablation. It's all thermal, but now we kind of cool it, we froze it to death. So basically, kind of this is the kind of cartoon showing how the freezing works. Basically, you freeze the cell, the water in the cells kind of enlarge, become crystal, and kind of shears the cells apart. And it also gets dehydrated. The cell outside the extracellular space, once you have water, turn into ice. Then the concentration of the increase the osmolarity of the outside, which kind of shrink the cell as well. It also blocks the blood vessel coming to supply the organ and the area. So that pretty much kills the cells. Not only that it kills during freezing, it's also killed during thawing. Once the temperature goes up, and the melted cells or the water chipped out again, and the endothelial damage that happens, the edema, followed by over time, inflammation, macrophage comes in, eat all these things, neutrophils comes in, and then apoptosis. And this is how ablation happens. This is similar slide, so I'm gonna skip that. But basically, the special things about cryo is actually you could do cryo mapping, because cryo has an area where you pretty much could try to see if functionally you can stop the cells from working and maybe map something like a pathway near the AV node. So that's cryo. That's a good thing about cryo. That's a cryo balloon during pulmonary vein ablation. There was a fire and ice study comparing RF ablation and cryo ablation. And yes, all the primary efficacy endpoint of the two are similar. The safety endpoint are both safe. These were meta-analysis using cryo ablation as a first-line treatment. As you could see here, there's less AF-AT compared to antiarrhythmic drugs. When comparing RF ablation to cryo ablation, they seem to be as good. As far as efficacy concerned, they are both as good. Now, so, okay, what is pulse field ablation? Pulse field ablation, now you need to learn the word electroporation. That's when you apply an electrical field to the myocardium or any cells, for that fact. The cell membranes open. So, and then it actually would close. Now, so, and these are the different pulse field shape and size and time that you can program. And these were the cell wall that's kind of open. And if you open it a lot, the cells kind of falls apart. So, as you can see here, there's reversible electroporation where it goes back, the cells go back to normal, or irreversible electroporation where the cells kind of completely disrupt. And for electrochemotherapy or gene electrotransfer, they use the reversible electroporation. Now, for us, for ablation, for AFib or any other tachycardia, we actually want complete destruction. So, there are many factors that affect the electroporation, starting from the size of the cells, how much energy we use. And again, you can see on the green part here, the more energy, the longer you kind of expose it to, at some point it will turn into a thermal ablation. There's the reversible zone, and then there's a reversible zone, the green one here, that's what we use. The shape of the field, the size of the electrodes, how many electrodes, how you emit the energy. It's also cell specific. So this is probably one of the benefit or potential significant benefit of having this energy. And again, the fibrillation of the cells specific organ. So, you know, for different cells, you have to come up with the different type of energy and delivery. So potential benefit of the pulse field ablation is this. So it's too small. So I write it for you. It's fast. It gives deep ablation. It's non-thermal. It's myocardial specific. So it doesn't damage the area on the side, the nerve, the esophagus, you know, at the structures. The downside in red there is no power titration. You just, you know, drop the bomb pretty much. It gives a large lesion. So something that you want to target small area, this is not the thing. You have to wait a little bit for the future. There's myocardial stunning. Importantly, there's gas bubble, you know. So this is a picture of the cells getting poured. So you can see all the holes there. But you can see here, the artery looks good, right? It's in there. There's no damage to the arteries. Again, this is comparing electroporation compared to RF ablation. You can see on the esophagus, it looks fine. So as you can see here, pulse field looks fine. No damage there. So that's the phrenic nerve. You see in green line, that these two green lines are phrenic nerve. Comparing the electroporation and RF, significantly different. As you can see here, the different sorts of energy: radio frequency, cryothermal, microwave, ultrasound, which is not very popular, laser, again, not very popular, and now pulse field ablation, which is like DC energy. It's just like going back for cardioversion of the old days when they ablate the AV node, but at a much shorter and lower energy. So importantly, the RF require contacts, cryo too. There's risk of thrombus and collateral damage on both. Maybe cryo is a little bit better, but there's no tissue specificity. Cryo, it may comes back once you kind of warm up the area. But then again, the pulse field contact may not be required, or maybe not that good. I'll show you later that may not be completely 100%. This has tissue specificity, and also reversibility is high. And again, down there, collateral damage is low, but there's some cautions to it. Again, thermal, gaseous bubble goes to the brain, muscle, you know, contraction every time you do cardioversion 5 times in 2.5 seconds. And it could be proarrhythmia, so you need to sync it. There's some news all the time that the newer device has a little problem, but usually followed by that the study is back on track and redoing it again. Both different companies, the other companies too. So pretty much all of them has that type of news. Again, the safety consideration, the esophagus, phrenic nerve, lungs, these are usually not much of a problem. Venous access is, you know, a little bit significant. It's a big catheter, so big cheese. Again, brain, microbubble, stroke, cerebral emboli, cardiac device, oversensing. The heart itself, usually the one that's significant, you know, tamponade, effusion, with big cheat, it's a big catheter, it's a little bit of a problem. The big catheter itself is less perforation, but if you perf it with a wire, it's a bit of a problem. You go in the wrong place. Now, coronary spasm is something that we are usually concerned while we're doing it. Pulmonary vein stenosis should have low risk, and kidney injuries. Again, with the lesion with pulse fields, you could see here that large area of these hyperstain red zone in yellow, as you can see there. Now, these are probably reversible areas. You can see here in the end after ablation. If on the first day you check, you look like you have a good big lesions, you know, on the 0 minutes. You follow it over time. The area of, you know, it may get smaller, and that may be the it's one caution that it may look great in the first day, but higher risk of recurrent on a later date. And contact seem to actually have some effect on the lesion size. So that also is something to talk about. And this the interfering of the pulse field over here on the pacemaker, but you know, you could just program it, it'll just record it, no problem about it. So this is Professor Nakadawa at the JHRS last year. A word he said was ablate-like health syndromes. If you do too much ablation, there's risk of kidney injuries, there's stroke risk, there's heart failure risk, and some proarrhythmia. So, you know, it's good. You just have to be slightly careful with it. Now, clinical trials, it has been a while. This back to 2019. First start with the 80 patient who does the ablation. You could see the pulmonary vein isolated right away. The success rate was good. As you can see here, over time, they changed the waveform, the number of pulse they use to kind of perfect the formula for ablation. Early on, there was, you know, the isolation was not that good, and that's why now every company has a different formula on how many times, how many energies, how to do the ablation for the veins. You know, so it's good. Oops. Well, anyway, so this is again showing that it's safe. Esophageal damage, dysmotility, fistula is 0. PV stenosis, there's no death, there's a little TIA, there's 1 effusion. And again, you know, like I said, it's a DC ablation for 21st century. And again, the efficacy is good. A different company also make pulse field ablation used for both paroxysmal and persistent AFib, 300 patient. And again, the result looks good. It's slightly lower numerically, but 70% compared to 80%, not bad. Now, the ADVENT trial, which was from 2023, comparing pulse field versus thermal ablation. As you can see here, the pulse field, this one should spare the esophagus and the phrenic nerve. And as it did, and again, as far as the pulmonary vein kind of stay wider. Now, the results are the same. You could see the graph are completely overlap. Even when you split to pulse field cryoballoon and RF ablation, pretty much similar. The serious adverse event are pretty much the same, both and no significant difference on the two groups. As you could see here in Manifest study, which is I think a registry, you could see that the complication are not pulse field specific. It's, you know, tamponade happens with anything, stroke, TIA, death. So it's, you know, it's the complication from the technology itself, it's quite low. And these, or the learning curve, kind of flat. So it's quite easy to do. And I guess that's one of the good part about it. Another registry showing, you know, is about 1,000 patients. Again, that it's safe. And then, you know, there's different catheter coming up, different shape. These are kind of focal. You can switch between RF and pulse field energy. And then you skip here, then there's a synchro shot, different looking catheter that can do PVI. Different type of RF catheter, as you can see here. I'm gonna finish it soon. Now, these are the circumferential PVI tools that we see mostly the FARAPulse, the Pulse Select I show you. These are the other catheter. And again, so these are coming up, and I heard there's a lot more coming out as far as so it's quite exciting to see how this thing goes. In the future, every company has one, probably, and some two. And these are the focal ablation. You can do a point-by-point ablation. These are smaller. You cannot tell from the pictures, but these are smaller catheter that deliver RF energy, and then, you know, get a focal ablation. So it's exciting to see what. So this is how we do it. I'm just going to skip that just to show we do some aortic LA injection just to see where the veins are, which we stopped doing it now. Wait, and that's a pulse field in action, and just we show early on. So I have to say, next slide. Okay, I'm gonna skip that for the sake of time. You know, this is the first AF ablation that not my first, but the fastest AF ablation that I did was like one RF ablation. This was 2.5 seconds. The patient's already back to sinus rhythm. It's quite impressive. So in summary, it's PFA is a tool that's perform irreversible electroporation for AF ablation. It's fastest way to get to PVI, and only for PVI for now. Minimal learning curve. Yeah, the downside that maybe the junior guys will not know how to map the left atrium in the future. It goes as good as safe as the other methods. Avoid doing too much ablation. There's complication to it. It's not without a problem. So, you know, what does? So just a little bit be careful when you start doing things. They have to say goodbye to an electrograms now. I guess people will stop looking at electrograms in the future. Okay, I think I'm done.
Okay, thank you very much, Professor Chachapong. Dear President, thank you very much for your nice comprehensive talk. Thank you. So right now we have opened a section for discussion. So any questions? So
yes.
So maybe right now. So I think the Professor Lin Junli just raised a question for you. That based on the currently evidence we have, do you have any preference of ablation based on radio frequency cryo or PFA? Any specific indication for each or in paroxysmal atrial fibrillation? Do you consider and give us some recommendation?
Personally, if I have to choose, I think it depends on a patient. I think certainly cost is still an issue in Thailand, so that's one thing. But let's say there's no cost. Someone who have those normal heart, AFib, minimal burden. Oh wait, I start my video. Let me see. Did I have my video up? Okay, so those are someone that I picked. Pulse field. Someone who I had tried either cryo or RF in the past, they have recurrent. Maybe I would consider pulse field because maybe there was some contact issue. Maybe I get to a different location or you know, cover the area I couldn't get there easily with the previous ablation. Someone who's really sick, like you know, someone who you don't want to doing it for too long. You don't want to be giving them a lot of fluids. Sick patient just kind of go in and go out because the time in the left atrium, which is, you know, much less. So those are probably the one that I'll pick. Pulse field. As far as pulse field and cryo, it's kind of hard to say. I mean, when you do it, it's a few less steps when you're doing pulse field compared to cryo. And if you're concerned, someone who had previous, like the one we're gonna have next week, that person has some esophageal problem in the past, so we're gonna try with pulse field. He had esophageal surgery or something before, so those are the one that I'm gonna pick pulse field. If they have atrial flutter, atypical flutter, I'm just gonna go with my usual RF ablation. How about you, YJ?
Yeah, so I think it will be, I think currently, based on current evidence, it will be similar between the RF cryo and the PFA in patient with the paroxysmal atrial fibrillation. But I think the long-term efficacy, I think we need to wait for more data to see that. And also about the repeat procedure, currently there are some evidence show that in patient with first ablation procedure was failed, maybe consider the alternative choice, different energy source. Yeah, so this is currently we're doing right now. But I think there are some indication for PFA. For example, there are some previous, because this is relatively simple and a short procedure and less risk for thromboembolism. I think it is quite well for some patients. Yes. Any
So we're
questions?
kind of in agreement.
Yeah.
Benny.
Yeah, hi.
Okay. Thank
See
you.
Yeah. Regarding the PFA, we just started in Indonesia just this year. I want to ask a question about how about if you do PFA? I have one case of did it become atrial flutter, typical or how do you map that and of, of, of the PFA?
Benny, maybe the voice is not clear. So yes, can you repeat your
From what
questions?
I heard, I think he's talking about mapping atypical flutter. Is that correct?
Yeah, I see. Flutter after the, and then how you map, and then how you.
No, actually, someone who I would like to map, I would actually do 3D map with RF. I think pulse field. Once you kind of map with pulse field, I think it's, to me, it's defeat the purpose of having pulse field. I think you want to do it without mapping. I don't know. That's my take on it. Now, as I show you, there's a good chance that the lesions will come back. I mean, that hyper stain area may recover. Even if you do good ablation on the first day and you map and it looks good, I think you run a chance of having a recurrent even when you do the map on the first day. So my personal take on this is actually just do the ablation and then save the 3D mapping for next ablation. That's my thought. Now, keep in mind that we have cost constraints. So we don't want to be opening a 3D and a pulse field. Yeah. When you open a 3D, then you have to open, the mapping and the ablation catheter, and then you open pulse field. I think for us that will be too expensive.
Okay.
Yeah. The cost constraint.
Yeah, the cost is an issue. Only rich people get pulse field.
This is a reimbursement issue for different country. Yes.
Yeah.
Okay, thank you very much. So we may move to the next talk.
Okay.
I get called to help with the case. See you later.
Yeah. I'll present so next speaker, and so Dr. Jin-Yu Lin, and Associate Professor at the National Yang Ming Chiao Tsang University, attending physician, Heart Rhythm Center, Division of Cardiology, Department of Medicine, Taipei Venetorian General Hospital, Taipei, Taiwan. He'll talk about innovative ablation strategy by substrate modification in addition to PVI in persistent atrial fibrillation, targeting rotors and skirts. Let's get started, please.
Okay, thank you for the introduction. I'm sharing my slide.
Yeah.
Okay. Thank you for the
please.
introduction. My talking today is about the substrate modification beyond the PV isolation in a patient with persistent atrial fibrillation. Although the previous speaker already said that PFA may ignore the EGM, but today my talk will focus on the EGM and how we modify the substrate beyond the PV isolation in the patient with persistent atrial fibrillation, and by talking about the rotor mapping software used in Taiwan, especially in the Taipei Veteran General Hospital and Taichung Veteran General Hospital. And the background of the persistent AF study is based on because the optimal ablation strategy for persistent atrial fibrillation is still not clear. We all know that the PV isolation is cornerstone for the AF ablation, but in a patient with persistent AF, sometimes the PV isolation may not be enough. And so we may need more ablation strategy for this kind of the patient. And we can take a look of the present guideline in 2017 and 2014, 24. There are some guidelines that substrate mapping with the voltage mapping for the atrial scar by the contact mapping or by the MRI. It's the approach and the ablation in this scar area is classified as a 2B indication for a patient with the persistent AF. And the guideline have a little bit different in the 2024. The MRI-based delay enhancement may not beneficial in the guideline of the 2024 in the EHI and the HRS and the APHRS. And also the rotor ablation in the previous public guideline. There is also 2B indication. Actually, there is no good substrate modification target in the current publication based on the present study. And so our purpose of the operation and how to improve the process in this kind of patient is our aim to investigate. And our aim is to do the approach for rotor, and this is the first study published by Halifei in the Nature, and he described the presentation and the characteristic of the rotor in our mapping. Actually, they defined a rotor have a rotational force and also a divergent force in the center of the rotor. And also we can observe peripheral fibrillation conduction beyond the center. And when we mapping the outside the rotor, we may identify only the fibrillation wave, but only in the center of the rotor, we can identify the both rotational force and the divergent force. And that's how we develop the mapping parameter for this kind of the rotor during the atrial fibrillation. We try to use the pattern of the AF wave propagation and identify the rotor behavior by using a multiple electrode catheter to map the vector field in the center of the rotor or in the area we map. We try to identify if there is a rotational force or it combined with a focal impulse in the mapping area, and try to identify the area with contain both rotational force and the focal impulse to find the suspect rotor area. And this is our previous study published in 2016. And at that time, we used a double spiral mapping catheter in the patient with atrial fibrillation. And we collaborate with the Central University with the Professor Mengzhong Luo to help us identify the signal during the atrial fibrillation and try to use the different threshold and try to make the signal become more clear and try to use the phase mapping to clarify the behavior of the AF signal during the atrial fibrillation. And we find that in the patient with atrial fibrillation and the computer simulation, the rotor area usually demonstrate characteristics that the EGM of the AF region usually demonstrate a similar EGM pattern. That's what we call similarity index. For the EGM, to purify the EGM, ignore the noise, and we can find that in the center of rotor, actually, the EGM will demonstrate a similar behavior in the center of the rotor. And by using this kind of mapping maneuver, we identify area with high similarity index, means that in this area, the EGM morphology or pattern will remain similar to each other in the same area. And we also identify how this F wave rotate in the mapping area to identify the rotational force and the focal impulse to identify the rotor. And by using this kind of maneuver, we use the ablation approach to targeting the area with high similarity index, and also compare with the traditional ablation approach in the persistent F. In that area, we use the cafe as a mapping as a control group. And actually, we can find that in the long-term follow-up, actually the F recurrence will be less in the patient receive the similarity index approach And by this maneuver, we reduce the AF recurrence and any atrial arrhythmia recurrence, but the atrial tachycardia and the flutter recurrence was similar between these two groups. And after the publication of the similarity index, actually we still keep on going to identify how to identify the rotor in the best way. And in our further study, we found that actually not only similarity, the EGM also have a pattern that some EGM change a little, but in a regular pattern. So the pattern of the several EGM may repeat again. Maybe after several milliseconds, there's a pattern of EGM again. And we found that this is also very important parameter in the center of the rotor. So we move this is the EGM, and we identified this EGM to several zones. And we found that in the center of the rotor, the pattern might repeat again after several maybe milliseconds or several seconds. And there is a similar pattern of EGM morphology in the rotor area, especially the driver area. And then further, we use this kind of maneuver, and we create the recurrent plot table to compare the burden, the pattern. So we collaborate with the Central University. They help us to do the signal processing. And by using this bandpass filter and signal extraction, and we purify the EGM signal into a more clear signal to comparison. And we can see that in this area with the red color, we can see that actually the similar EGM pattern repeat again and again. After maybe 0 beat, the similar pattern repeat again. And we call this the long length of the repetitive pattern. We call that is a periodicity. And by using the periodicity and the similarity index and of the pattern, we call this a new parameter as a prism, because it combined with the similarity and the periodicity by using the cross table to identify the potential rotor during the atrial fibrillation. And this is a computer simulation of the rotor wave, and this is the core of the rotor, and this is the area nearby the rotor, and this area is the area surrounding the rotor but far away. And we can see that in these three areas, we map and record the EGM signal. And after the signal processing, and we change it into a recurrent plot. And we can see that in the area of the central of the rotor, there's a more high similarity and a high pattern, longer periodicity of the EGM pattern in the center of the rotor. So they have a higher prism value, means the recurrent pattern morphology repeatedly can persist for a longer period. And in the of the rotor, actually, we can see that the similarity index is a little bit lower, and also the repetitive EGM pattern, the duration is also shorter. And by using ROG comparing with the previous similarity index and the previous tool, like dominant frequency, we found that this new parameter, by using the similarity plus the periodicity, we have a better power to identify the center of the rotor. And also the recording time is measured by using a multiple electro mapping catheter putting in one area. And we can find that the value of the repetitive pattern and the prism value become more stabilized after 6 to 10 seconds, and the value will be stabilized and no change after this period. So we set the recording time as 10 seconds for the recording of the present value to identify the center of the rotor. And in the lower panel is an example that we show after maybe for 10 seconds. Actually, the mapping of the prism area will be almost the same. Despite we increase the mapping time, actually the rotor area is still the same. So 10 seconds is enough for a mapping in one area to identify the rotor. In this study, we use a study and compare the patient with the previous study using only the PV isolation. So this is a case control study. And by using in this study, we use the pentarray. By using this kind of bigger multilateral mapping catheter, we can collect the whole atrial fibrillation wave in a shorter time. And we identify actually the AF patient, we classify into two groups. One group is that we identify only the driver, means a high prism area around the PV or in the entrance of PV. In the two that we means that we identify more driver in the LAA body outside the PV. So in the first patient type of patient, we do the PV isolation, and we found that in this kind of patient, the patient have more chance to terminate the atrial fibrillation by using the PV isolation. So in this group, we do the PV isolation only. And in the type 2 patient, usually the PV will not be terminated by the PV isolation, and the more substrate modification in this high prism area might require. And then in some patients, this approach might terminate the AF into a flutter or terminate the AF. And in this previous study, we published in a circulation AE, and we found that the PRISM approach have a better outcome in the atrial fibrillation recurrence. And also we identify some difference in the type 1 and type 2. If the patient have only pure rotor in a pulmonary vein, actually the F recurrence rate will be lower. So this can also be a tool to do the risk stratification regarding the F recurrence. And because the previous reviewer for the circulation A, they say this is not a true prospective randomized control. So we conduct the prospective randomized control study after the publication of the circulation AE. And in this prospective study, we enrolled 170 patients into two approach. One received a conventional approach by using the PV isolation, and another is use the PV isolation plus the PRISM guide approach. And beyond the PV isolation, we also do a non-PV trigger ablation, and also if the AF terminate into the atrial tachycardia or flutter, we also map the flutter and do the catheter ablation. And half the patient actually do PVI with pearl balloon, half do the catheter ablation. And this is the patient characteristic in our study. And because this is a randomized control study, so actually in the patient age, sex, and the body weight, and the underlying disease, and the echo parameter, including the LA diameter and the ejection fraction. Actually, two groups did not have a significant difference regarding the baseline characteristic. And this is a procedural detail, and we can find that actually the parameter is also similar. Regarding the additional ablation or non-PV trigger ablation, actually there's no significant difference between the procedural parameter. And this is an example of the type 1 patient. And this is, we can find that the prism map identify only a focal driver in the LSPV. So our approach is to do the PV isolation alone. And in this patient, actually the PV isolation terminate the F into the sinus region. But actually the PV termination rate is not 100%. Many patients still require the cardioversion after a PV isolation. And this is a type 2 manifestation. And by using the prism mapping, we found a rotor, a driver in the RSPV, LSPV, and also the appendage, and also the posterior. And in our current study, actually, we did not target the appendage side. So we only target the posterior driver. And during this approach, because there's a posterior driver, we also do the box, and the AF was also terminated in this case presentation. The AF was terminated into the sinus region. And actually, we found that this is a distribution of the high prism area and the suspect driver area. And we found that most of the F driver might locate in the LAA septum, and also some in the posterior, and some in the mitral area. And the other driver location is including the anterior wall and the appendage and the roof. And this is a long-term outcome after the randomized control, and we found that the prism group have less atrial fibrillation recurrence, and also less any arrhythmia recurrence. Similar to the previous study we published in our journal, that actually the AT or flutter recurrence is similar despite a prism approach or conventional PV isolation. And by using this approach, we decrease the AF recurrence in the patient with persistent atrial fibrillation. And also after the study, we also do a multivariable prediction for the recurrence. And we find that in the patient with non-PV trigger, and also the use of prism mapping and approach may have use the prism approach have less F recurrence, but the prism of the non-PV trigger was associated with more F recurrence in this kind of patient.
Some of the guys, yes,
and this is the left line, and this is a conclusion. And in type A VGH, we try to use the driver mapping to improve the long-term outcome of a patient with persistent atrial fibrillation. And we found if we can use this electrogram morphology similarity and the repetitiveness mapping can reduce the AF recurrence in this kind of patient with persistent atrial fibrillation. And the mapping methodology and the mapping time, actually after the revision and the improvement, actually already decreased the mapping time and the procedure time. And actually in our study, we found that the mapping time and the procedure time is maybe 10 or 15 minutes more than the conventional approach. And this kind of mapping, by using this novel algorithm, may decrease the more extensive substrate modification based on the scar area, because we can try to find where's the driver and do the local ablation. No need to do the extensive scar homogenization. And by using this maneuver plus the non-PV trigger ablation can reduce the F recurrence. And also this result was proved by the multi-center study with the randomized control study. And in the future, we may do more study and try to confirm, validate the reproducibility of this study and this prism ablation. Thank you.
Thank you very much for the Dr. Lin. This is all your work in that, so it's very excellent work in that. So I'm surprised about that. Your work is the prism guided ablation is superior to the other conventional study. This
Thank
is
you.
nice work in that. Are there any question in the audience that I wanna ask you a question? So regarding the rotor, generally, so how many rotors has a persistent AF have? How many rotors generally?
In a
Yeah,
patient with the persistent
persistent and
atrial fibrillation, in our recent data collection, one patient may have 2 to 405 rotor in a mean, 2 to 4 area of rotor per one patient.
oh really? And
But actually, in some patients may have only 1 or 2, but the mean is around 2 to 4.
What's the determinant for the number of the rotor? Is that the long duration of the AF have much rotors or? Yeah.
Actually, we did not directly compare, but in the previous publication, we have do some sub-analysis. In a patient with a longer AF duration, like a long-lasting AF or very big size of the left atrium. Actually, some patient might not identify any rotor in the LA. Yes, so usually the more rotor in the nearly persistent or new persistent atrial fibrillation, this kind of patient may have more chance to identify the rotor in our experience.
Okay. Thank you very much. The strategy of the prism guided ablation is quite unique, and so it's a very reasonable. Yeah, I think is there any comment or questions, audience? Okay.
Okay, thank you.
Is that okay?
So okay.
Okay.
Yeah, thank you very much.
Thank you.
So
Yeah.
okay, so we'll move to the next talk. Will give us by another chair, the Dr. Yasuo Okamura from Japan. So he is the chief professor and the director for the cardiology in Nihon University School of Medicine, and also the vice director of Nihon University Itabashi Hospital, Tokyo, Japan. So today he will give us a talk, rhythm control by catheter ablation strategy in patients with heart failure with atrial fibrillation under optimal medical therapy. The heart prep versus heart prep. Yeah, so Professor Okamura, please.
Okay. This is my slide. よいしょ。これでいいのかな? Okay. Can you see the slide? Is that okay?
Yes.
Okay. Yes. Thank you for some introduction for me. So I'll talk about the rhythm control by catheter ablation strategy in heart failure with atrial fibrillation and optimal GDMP. And actually, so comparing the HFrEF versus and the HFpEF, but I'll more focus on the HEMrEF mid-range and mildly reduced EF is also. And this is my COI. And this slide shows the Japanese largest registry CHART2 called CHART2 study. This slide shows the natural cause prognosis of the HFrEF and HEMrEF and HFpEF. As you can see, so based on the largest this registry is all cause deaths in the CV deaths and non-CV deaths. As you can see, this is a red line is a HFrEF. HFrEF is a worst prognosis as compared to the HEMrEF and HFpEF. And regarding the HF heart failure admission, and HEMrEF is a little bit worse as compared to the HFpEF. And this is so time course of the natural time course of the type of the heart failure patient. And most of the number is 2,000 in the HFpEF patient. In the 1 year, the time is passed in the but most of the 80% of the patient is a HFpEF. But the HemRef patient in the 1 year, 2 year time is passed in the where time is passed in the goes up to the HFpEF, and 40% of the patient HFpEF, and the remaining sustain the HemRef. And some of the patient, a small number of the patient, and about 20% of the patient in the goes down to the HFref. And so regarding the HFref, and this is and some of the patient, in the 20% of the patient transition to the HFref, and 20% of the patient is a HemRef. And the prognosis of these time course change, considering the time course change, regardless of the HFpEF and the HemRef and the HFref. And so the patient in the transition to the HFref patient is a worst scenario in the clinical outcome. And this is about the after the LV improvement of the LV improvement improvement of every function after the ablation, comparing the HFref and HemRef and HFpEF. This is a Japanese study. This study report is I think the 50% of the about 50% of the HFref patient improve the ejection fraction, and goes up to the HemRef or the HFpEF patient. And the HemRef patient is 62% of the increase, and then transition to the HFpEF patient. And the other scenario, the other paper is also about half of the patient improves the HFref is improved after the ablation, and so 80% of the HemRef patient improved. The other study is also quite similar, and the 50% of the HFref patient is improved, the LV function is improved, and also 60% of the HemRef patient improves. And together, I think that after the ablation, the 50 to 80% of the HemRef patients show the improved AF and transition to the HFpEF patient, I think. And about half of the HFref patients experience a LV improvement and then transition to the HemRef or HFpEF, some of the patient. This is the result. And this slide shows us improvement in LV function after the ablation versus medication on the HFref patient. And most of the clinical trials show that as you can see as you know, the LVEF as following a catheter ablation is increased and after at 6 months or 12 months after the ablation, like this. The gradient of the LV function is I think the meta-analysis shows that regarding the HFref patient, the ablation group is increased up to 10% of the AFib ejection fraction improvement. And but medication is only about 3% of the increase of the LV function. Therefore, the significant difference in the LV improvement in the almost 7% of the improvement of EF versus no ablation group. This slide shows a HemRef patient. HemRef patient is a very limited data. So this slide shows from Taiwan, there's a propensity score matched cohort in that only 70 HemRef patient treated with catheter ablation and compared to the 72 patients receiving medical therapy. As you can see, the LV change is group 1 is catheter ablation increased in the 25. It's much significant, much larger, greater than that. So as compared to the HFref. And so group 2 is a medication group, is only 6%. This is quite similar to the previous slide. And as you can see, you know the camera MRI trial. This is the inclusion criteria. Every patient is a persistent AF and HFref in this study, but in detail is the inclusion criteria, the ejection fraction is 45%. Therefore, so half of the patient, the ejection fraction is so more than 35%. That means I think is the most half of the patient is I think the quite the like a hemorrhage patient, I think. And in this study is so after catheter ablation, the ablation group, the LV improvement is almost so 20%. It's very great. And so then so most of the patient is so 60% of the patient in the goes up to the ejection fraction over the 50%. That means that so HFpEF transition to the PFPEF. And rate control group is only 9%. And in this trial, as you know, so this trial, so all patient had a so MRI, cardiac MRI, and low LG positive patient is a lower improvement as compared to the absence of low LG patient. LG patient is I think that's the improvement of the LV function is 22%. It's a very great. That means I think it's the most recent study shown that the hemorrhage patient experienced a significant EF improvement compared to the HFrEF patient, I think. Often lead to the EF normalization, I think. This data suggests the majority of the hemorrhage patient may have reduced EF primarily. I think, in my opinion, due to the AF without evident underlying heart disease, like a no LG patient, I think. So therefore, in my opinion, the hemorrhage patient is like a tachycardia induced cardiomyopathy, maybe, in my opinion. And this slide shows so sinus rhythm maintenance rates among the comparing the so HFrEF and hemref and HFpEF. As you can see, so all studies show the so sinus rhythm maintenance rate is so HFrEF compared to the so HFpEF and the hemref patient is sinus rhythm maintenance rate almost equal. Well, some studies lesser lower sinus rhythm rate, but most of the study is so quite similar to the HFpEF patient regarding in terms of the sinus rhythm maintenance rates. And also the HFrEF is also sinus rhythm maintenance it's not so different from the so hemref rates. Overall, regardless of the HFpEF and the hemref and the HFrEF, I think the sinus rhythm maintenance rate is quite similar among the three types of the so heart failure patient. And this is the sinus maintenance of AF burden ablation versus medication. The HFrEF patient meta-analysis shows that and ablation groups with the sinus rhythm maintenance rate is 72%, medication and only 22%. Therefore, there looks 60% reduction versus medication. And the hemorrhage patient, this is the previous in the study in the AF burden follow-up is so sinus rhythm is so 70% is success rate is 70%, and persistent is AF burden was very lower in the 25.5 as compared to the medication group. And this is a HFpEF meta-analysis. And this slide shows the 47 reduction versus medication. Therefore, so I think it's so sinus rhythm maintenance rate is so HFrEF and the hemref is quite good in the as compared to the medication. Also, the HFpEF is quite good. And this slide shows the improvement of symptom and QOL. And NIHA, this is a QOL. This study is the NIHA. As you can see, so NIHA is quite similar after the ablation, the HFpEF and hemref and HFrEF. This is a post-ablation. That HFrEF is after 1 year. It's all the type of the ablation is improve the symptom, and the QoS is all the type of the the heart failure type is so improve the QOL, but so most significant in patient is a hemref patient. And NIHA is also quite similar. Is in this paper, and the hemref equal in the improvement symptom is so HFrEF is 60% of the patient, and HemREF is 63%, quite similar. And HFrEF is a little bit lower symptom and increase. And therefore, I think it's most of the and type of the regardless of the heart failure type, I think the symptom QOL improves quite similar, I think, in my opinion. In fact, there are some and the other stuff is so this is a hard endpoint. Heart failure admission and mortality among the HemREF and HFrEF and HFpEF. I think it's in this study, so hospitalization and death, and this is a hospitalization. As you can see, the HFpEF is a better clinical outcome, and but also the HemREF is quite similar, but HFrEF is the worst clinical outcome, and also therefore this trial, this study, and the reduction is quite similar. And the other study is HFrEF is worst. And the other study, almost HemREF to HFrEF is quite similar. And in together, I think the heart failure admission and mortalities, and HFrEF and HemREF and HFrEF, I think it's HFrEF is the worst scenario as compared to the HFpEF and HemREF. This is my opinion. This is this slide shows us heart failure admission and mortality on HFrEF ablation versus medication. As you can see, the CASREF trial, the complete outcome, death and worsening heart failure reduction is 38% reduction and 47 reduction and in the ablation as compared to medical therapy. And hospitality, heart failure admission is a 34% reduction. Regarding the CASREF HTX trial is also significantly decrease the composite and primary composite event, any cause of death, and also the LVAD and assistant. So this is a meta-analysis on the HFrEF patient. This is the heart failure admission is a meta-analysis shows a 41 reduction of that compared to the medication therapy. All cause death is also the 37% of the reduction of the as compared to the medical therapy. This is I think it's a very strong evidence because of the most of the study is comes to deliver from the RCT. But limited data regarding the HemREF patient versus and ablation versus medication. This is the observational study and propensity matched cohort in the previous study. The adjusted hazard ratio is 0.09. That means 91% of the reduction on the heart failure ablation, and mortality is also the 88% of the reduction and the ablation as compared to the medical therapy. This is our study in the CVDS and the HF ablation. This is a combined HFpEF and HemREF, but significantly decreased is the HV cardiovascular death and heart failure admission as shown here. This is the East AFnet for trial, post hoc trial. I think it's reduction rate is not significant, but 20-30% of the reduction. This is a Cabanas trial post hoc trial. Mortality rate is not significant, but 60% of the reduction was observed, relatively observed as compared to the medication. This slide shows the HFpEF. HFpEF is limited data, ablation versus medication. This is a meta-analysis. This is most of the all the trial is study is an observational study. As you can see, it's a 56% of the heart failure admission is reduced as compared to the medication, and all cause death is also the 25% reduction. But this is not statistically significant. And only this is this meta-analysis only shows the RCT sub-analysis. But the RCT sub-analysis shows that there are no difference. Only there are no significant difference regardless of the heart failure admission, the all-cause death. Therefore, I think observational study is, I think it's, we need more data about the HFpEF. And this is, so this slide shows us, so risk reduction rate versus medication. I think it's as you can, this error bar is a risk reduction rate. As you can see, I think with a HFpEF patient, I think mortality is around 5 or 60% reduction. Heart failure is 3 and 64 reduction. Composite is like this. And HFrEF is mortality is about 50 to 70, and HF is 40. Composite is 50. Therefore, I think seems it's much stronger as compared to the HFpEF patient. And also the HFrEF patient mortality is about 6 to 90%. Heart failure is very low, and composite is also the significant reduction as compared to the HFpEF, at least HFpEF and HFrEF. Therefore, I'm not sure the exactly the minimum effect is, I think, HFpEF, and moderate effect is HFrEF. I'm not sure the exactly, but HFrEF patient is so strong prognostic effect is observed. I think it's a ablation. I'm not sure it's exactly because this is almost no RCT. This is only the sub-analysis, and the RCT sub-analysis is a registry. This is a Japanese recommendation in the evidence level. And this is a guideline. AF patients with HFpEF don't have comorbidity. It's a class 2P. I think it's at this point is I think class 2B is reasonable because there are no data about the mortality in the hospital and the rate in the only the observational study. I'm not sure the increase clinical class evidence. And some patients HFrEF is I think it's class 1. And the other stuff is this is AF strongly suspected having reduced due to AF without even underlying heart disease. That means I think it's a tachycardia-induced cardiomyopathy. That's majority of patients. I think this would be the HFrEF patient. This is the most the benefit of the patient in the as compared to the HFrEF or HFpEF, in my opinion. And conclusion, ablation offers a significant improvement in EF symptom relief and QOL, HMREF, and with outcome often comparative or better than those seen the HFpEF and HFrEF. However, the more research is needed to clarify the long-term impact of ablation, especially in the HFpEF and HMREF, particularly regarding the heart failure admission and mortality. Thank you very much.
Oh, thank you very much,
Yeah.
Dr. Okamura, for your nice and comprehensive talk regarding the heart failure in patients with atrial fibrillation. I think you provide many evidence to show us the prioritize of the atrial fibrillation in heart failure patient. Thank you. So
Thank you.
maybe I have a short question. So I agree with you that based on your evidence you provided, that how can you give us the most of the clinician the recommendation? Do you recommend to prioritize the catheter ablation in patient with heart failure with half ref versus half puff? More evidence in the half ref in half puff and half puff compared to the half puff. Because currently we know that many the guidelines recommend that heart failure should be the class 1 indication.
Yeah. I think you told me that, so HFpEF patient?
Yeah.
Hey.
So do you see the prioritize the catheter ablation in patient with a half ref versus half puff? We have more evidence to show that.
Yeah, I think it's also we need more evidence about the HFpEF patient. I think the HemREF patient is I think it's a class 1 is okay. I think it's most or the many of patients should be do the ablation. Strongly recommend the ablation, but HFrEF is also I've strongly recommended. Yeah, but HFpEF patient is this is dependent on the I think the age. Age is the most important factor. I think because we have some data. This is not still open. So now I analyze the data over patient is aged over 80. I collecting the so a lot of 70 100 patient in Japan now. So and the result is not I don't have this is result, but I think it's aged over the 80. The in the first patient, there are no effect of the the clinical outcome regarding the mortality or heart failure admission. I think it's important stuff with the age. I think it's less than 75%, less than 75 years old. I think it's the catheter ablation will be effective for the inpatient with HFpEF, I think. But more than 75, I think it's no prognostic effect in the
Yes.
yeah, maybe no effect. But importantly, the important stuff is symptom. Symptom is I think it's improves regardless of the if the patient has a symptom in the and the HFpEF, and if the patient is want to do the ablation, and then we'll do the ablation. But this is a very difficult recommendation. I am not recommend that. So it as a to improve the outcome, not outcome, just only the symptom in such cases. Yeah.
Okay.
Yeah.
Thank you. Agree with you. Thank you very much.
Thank you very much.
Okay. Yeah. So I think time is over. So maybe we'll move to the next talk.
Yeah. Next talk. Sorry. Next talk is next talk, and I'll introduce Dr. Benny Hatono from Indonesia, head of the invasive cardiology division, the Inawarua Cardiac Center, Jakarta, Indonesia. His talk is about the left atrial appendage closure, prevail oral anticoagulant for stroke prevention in atrial fibrillation. Indications talk. Go ahead, please, Dr. Benny. Handle. Okay. You can see. Your voice is off, so therefore the
Benny, your voice. Please.
your voice is please on the voice.
Oh
Okay.
yeah. Also sorry. I share again. Sorry.
Oh, please.
You can hear me now?
Yes, I can hear you. Okay.
Okay.
Go ahead, please.
Okay. Yeah, my talk is about the LAA closure preferred oral anticoagulant for stroke prevention in AF patients. This is an indication talk. This is my outline. And we know that atrial fibrillation is the most common cardiac rhythm disorder. The prevalence is growing up each year and become the leading cause of stroke. There are 5 times increased risk of stroke of AF patients. From the overall stroke that occurs, about 1 out of 6 is a patient with AF. And interestingly, about half of the patient will suffer a second stroke within 6 months from the first episode. And we know that the status of the thrombus in the LA is the predictor of the TIA and the ischemic stroke for the AF patients. And from the several study that there is about 90% of the patient with stroke have the thrombus in the LA in non-valvular AF. But in our country, in the valvular IF, especially in the rheumatic IF, we find about 50 to 69% thrombus in the LA. So this is the current treatment of the stroke prevention in AF. Oral anticoagulant is still the mainstay of the treatment for stroke prevention. However, there is an alternative. If you have a high-risk bleeding, you can consider the percutaneous LAA closure, or if the patient have a plan for surgical procedure or CABG or fast surgery, maybe a surgical LAA closure can be considered. However, the use of anticoagulant, although it is very frequent use in clinical practice, there is still a problem when using the anticoagulant. We can see here from the landmark trial, the bleeding risk occur, including intracranial hemorrhage, even though it's lower with the DOAC, is about 2 to 4% annually. And the compliance of the patient that taking oral anticoagulant is decreased over time. You can see that 30% of the patient taking oral anticoagulant discontinue after 2 years. And other problem is the underuse or underdosing. We know in the Asian population, the underuse of anticoagulant is can be found in the registry in the Korea, Taiwan, that showing that patient may be afraid to take because of afraid of bleeding and risk of fall, and etc. And also in Asian population is more underdosing of the anticoagulations. And we also see the recurrent stroke after OAC is also, despite they have the oral anticoagulant, the recurrent stroke is still occur. And of course, if we see the long-term cost for taking a long-term anticoagulant, it will exceed the other procedure like LA occluder. And other side effect that GI or bleeding that can make the patient discontinue of the oral anticoagulant. Now, this is against prospective study, cohort study, showing that patient with the oral anticoagulant usually will drop the anticoagulants after 2 years, about 30% for the DOAC and 50% of the pKa. And again, in the patient with the ischemic stroke, they also have a oral anticoagulant, they can have another stroke episode. Yeah, this is a pool analysis of the 7 prospective cohort study of more than 5,000 AF patients. The median CHART score is 5. And the results showing that prior oral anticoagulant use is associated with increased risk of recurrent ischemic stroke. The change in the oral anticoagulant is not associated with the decreased risk of ischemic stroke. And annual risk of recurrent ischemic stroke in patients who had AF related to ischemic stroke while have on oral anticoagulant was 8.9%. Is more higher than the CHART score than 5. And then this is highlight the need of better strategy to prevent the ischemic stroke. This is another study that if you have an ischemic stroke and then changing the oral anticoagulant, actually is not helping also. This is a retrospective cohort study on the about 2,000 patients. Compare it if you have a stroke and whether you retain your anticoagulant or you change your DOAC. So the recurrent ischemic stroke was similar with DOAC change and DOAC retains, but the higher incidence of intracranial hemorrhage on the DOAC change group, but no statistically significant. So if you have an ischemic stroke, so already on the oral anticoagulant, changing the oral anticoagulant to another type of anticoagulants that did not help also. So we need to have another alternative in patient like this. So we know that LAA occluder have been introduced about 20 years ago, and then from the first time it's like Watchman, so have another type like Ablation, and so now in development is laminar, and also the surgical like atrial clip, etc. Yeah. So until the introduction, until now, about 250,000 people have implanted the LAA occluder. And this is, I want to highlight the previous trial, the most robust RCT from the Protect and Prevail, comparing the Watchman to the warfarin. If we see the efficacy, there is no difference of the ischemic stroke. However, if we dissect further, that there is a decrease of hemorrhagic stroke and CV and spleen death in the Watchman group. And also, the major bleeding is also lower in the Watchman group compared to the warfarin. And of course, we know that intervention is without any risk. Yeah, the risk in the early days we see in the Protect AF, the pericardial infusion is quite high. Periprocedural stroke is also high, about 1%. PE about 4%. But over times, they do another study, Prevail, CAP, is going lower. And the registry of the real world evolution and US cohort is become very low. The complication rate or PE is lower than 1%. And furthermore, we see the 5-year outcome of the LA closer. The ischemic stroke, comparing the LA with the warfarin, was numerically higher with LA closer, but it's not statistically significant. That's why the guideline has changed from the 2B indication. We see, but however, the LA closer associated with reduced hemorrhagic stroke, disabling or fatal stroke, CV death, and all-cause death, and major bleeding. And if the previous study comparing the LA with the warfarin, how about the DOAC that more powerful than warfarin? This is another randomized study comparing the Watchman with the DOAC. Yeah, this is a small study but randomized 400 patients with high-risk CHART score 4.7 that has bled 3.1 that follow up for 3.5 years. And we can see for the primary endpoint about stroke TIA, stroke embolism, and CV death, there is for the Watchman arm, LA occluder arm is lower there compared to the DOAC, and is significant for the non-inferiority. And then from the stroke or TIA is the comparable, same. And for, however, for the non-procedural clinical relevant bleeding, we can see that the LA occluder is more favorable compared to the DOAC. So this is the combined analysis of the 3 randomized trial, Protect, Prevail, and PRAG. And again, it's emphasized that the hemorrhagic stroke, the cardiovascular mortality, all-cause death, major bleeding, and non-procedural related bleeding is favorable for Watchman for LA occluder compared to the anticoagulants. And this is another meta-analysis just to emphasize that for the efficacy is the same. However, for the bleeding rate, LA occluder is more preferable compared to DOAC. And we know the technology is improving also to prevent the complication during the procedure. Yeah, the Watchman improved to the Watchman Flex. Yeah, we can see that he have a shorter device, so can put in the more short appendage. Yeah, and then he have a distal tines fallback, so it's more safe for us to recapture if we don't put in the certain place, then more recapture is can be done, and greater number of stroke is mean that so the conformability of the LAA device to the LAA appendage is more good, and dual row anchor, so is prevent the emboli and reduce metal exposure to reduce the thrombus-related device-related thrombus. Yeah. So we can see of the trial of the new device, Pinnacle Flex 2, the event rate is quite low compared to the old Watchman device. And for the Surpass is NCDR LAO registry, you can see the consistent low safety endpoint, and so also the low of ischemic stroke and major bleeding. So what is the indication? From the AC guideline, is still the same. We see the class 2B for the percutaneous LAA occlusion may be considered with AF patient and contraindication for long-term oral anticoagulant to prevent ischemic stroke and embolism. However, in the ACC AHA recommendation, there is an increase and more clear definition about this. With patient with the AF with the moderate to high risk of stroke, a contraindication to long-term oral anticoagulant due to a non-reversible cause, LAA occluder is reasonable, is class of recommendations 2A. And in the patient with AF and moderate high risk stroke and major bleeding and oral anticoagulations, LAA occluder may be reasonable alternative to the oral anticoagulant. So what is the long-term anticoagulation contraindication is if you have a severe bleeding that is non-reversible from the gastrointestinal, pulmonary, or genital urinary system, or there is a spontaneous intracranial bleeding, serious bleeding related to the recurrent falls, or the falls is not felt to be treatable. So what is the other indication beyond this? Maybe we can see if the patient have the specific hemorrhagic disease. Yeah, if he have the hereditary hemorrhagic disease like cerebral amyloid angiopathy, hemorrhagic telangiectasia, or moya disease that find more in the Japanese populations, or age-related macular degenerations. Maybe LAA occluder can be proposed for this kind of specific hemorrhagic disease. Or there is a persistent thrombus in the LAA. Even though we know that if there is a thrombus in the LAA, usually we give the oral anticoagulation first because it's contraindicated to do the procedure. But some report has shown that we can put in the LA, even though I never do that, with not parts of the LA using the device with the disc. Yeah. And also after AF ablation, or if we do a more extend ablation like LA electrical isolations, yeah, maybe this kind of patient we can put the LA occluder. For the patient with the end-stage renal disease, we know that end-stage renal disease have a high risk of bleeding, also high risk of thrombosis, yeah, and no study from the DOAC use the patient with the end-stage renal disease. Maybe this kind of population can have the LAA occluder. Or in the special population that have low adherence with oral anticoagulant, like in our population, we separate in the different island that may be difficult to reach the center. So maybe they don't take the medication regularly or control it. That maybe this kind of population we can put the LAA occluder. So this is one of the study, stroke rate with atrial fibrillation undergoing LAA electrical isolations. Yeah, so we can see that after 6 months of the LAA electrical isolation, they divided in 2 groups. Yeah, and then all patients with the normal LAA functions, they off the anticoagulations, but the impaired LAA function, they divide with the off anticoagulation than on oral anticoagulations. Yeah, and we see with the normal LAA functions, the event is 0, even though you off the anticoagulation. However, with the abnormal LAA function, you can see the off oral anticoagulation increase the stroke rate. So in the conclusion of the study, in this kind of population, if you do extend LAA, electrical insulation, LAA closure strategy allow a safe anticoagulation discontinuation in a small group of patients. Now, this is the current trial, the option trial, comparing the LAA occluder with the oral anticoagulation after AF ablation. This is a multi-center randomized about 1,600 patients. After AF ablation, they use the Watchman flex compared to oral anticoagulant. Mean age is 70 years, just fast 3.5 follow-up about 3 years. Primary safety endpoint, non-procedural related major bleeding or clinical relevant non-major bleeding. The primary efficacy endpoint is composite of death, stroke, and systemic embolisms. And secondary endpoint is major bleeding. And we can see here the ablations divided from persistent to paroxysmal. More than 1 year or less than 1 year is about equal, but they divided the sequential occlusions, after the ablations. So the ablation first and the sequentials, 90 after 180 days is 60% of the patient, and they can do a concomitant directly to procedure concomitantly or within the 10 days is about 40% of the patients. And if we see the primary safety endpoint about the non-procedural related major bleeding, you can see the device is perform better compared to the anticoagulations. And for the primary efficacy endpoint, the composite of death and the stroke and systemic embolism is about the same. Yeah, so is LA occluder for long term is have the same effect with the oral anticoagulations. And secondary endpoint about the major bleedings, so we can see the device is perform better even though there is no statistic significant. So in conclusion, the air closure after AF ablation, whether we do it sequential or concomitant, reduce the non-procedural related major bleeding and clinical related bleeding, and had similar efficacy to prevent death, stroke, and systemic embolism at 36 months of follow-up. So this is the summary of my talk. That we know that oral anticoagulation, especially DOAC, is still the current mainstay of the stroke preventions, but we may consider LA occluder for the high-risk stroke of AF patients that contraindicated to the oral anticoagulant or could not tolerate long-term oral anticoagulation or have a high-risk bleeding risk. Other indication beyond the guideline may be recurrent stroke despite of oral anticoagulants, specific hemorrhagic disease, end-stage renal disease, persistent thrombus inside the LA, post-LAA electrical isolation, post-IF ablation with concomitant or sequential procedure, or patient with low adherence of oral anticoagulant. Thank you very much.
Hi, thank you very much for your nice presentation and so comprehensive result from the major trial. And is there any question or audience or? And I have a question. So the option, I'm very interested in the option trial. You know that what do you think the option trial about that? Yeah, because after the concomitant the left atrial appendage occlusion and catheter ablation is, in my opinion, it's a little bit too much in the but what do you think about that actually? To honestly.
Yeah, honestly. Okay, in some population of patients, if we see that if he have a AFib and we know maybe if we do ablations that the recurrent rate is maybe quite higher, persistent, or maybe we can offer them to do concomitant ablations and with the LA occluder. We did it several of our case. Usually it's more older, and then the LA dimension is quite more bigger, so the recurrence rate is more, and then he have a high risk bleeding features. In that kind of case, maybe we can do the concomitant procedure for him. So we do one times, and then we prevent the stroke also for this kind of type of patients.
And the other stuff is so the problem with the appendage occlusion is so most of the patient in Japan is also so most of the patient is so appendage occluder patient is indication is for the so major bleeding the patient. So therefore most of the patient is very old, over the 80 years old. So, but so cost effectiveness is not so good actually, because most of the patient is so the major bleeding high risk patient is so will be dead. I think so. I think 1 or 2 years after 1 or 2 years, based on my data.
Recent study. Sometimes in the patient with high risk bleeding, they also cannot tolerate the short term of anticoagulation after we do the LA. But current trials showing that if they cannot tolerate, they can give a dual antiplatelet for that short term period. Continue for 6 months and then single antiplatelets.
And I think, do you think that so indication is so widely spread to the younger patient? I think the concomitant PVI and high risk patient, and also the need so appendage closure. It's so cost effective. I think it's low, maybe because they don't need so DOAC is no longer. So therefore I'm not sure exactly. So in the United States, it's very strongly recommended. I think the guideline based on the guideline. So I think
if we see the option trial, actually the Hasblat score is about 1.2. The mean it's not very high risk bleeding patient actually.
So therefore, I think it's a indication for the sort of left atrial appendage plus in the PV isolation is I think the younger patient is much better.
Maybe.
What do you think?
Maybe we can offer that for the patient.
I'm not sure exactly, but
because if we know that the ablation is very effective, that the patient will not have the recurrence. In the sinus system, maybe we don't need the oral anticoagulation for the long term.
So
I don't know.
I'm not sure that's the exact answer. So is there any question or is that okay?
Okay, thank you.
Thank you very much for your nice presentation. So time is over, I think. So in closing, today is also our session, the atrial fibrillation about the atrial fibrillation management, and we have a lot of topic in the screening is AF prediction and catheter ablation and stroke prediction. I think it's highlighting the need for a comprehensive approach, I think, for the AF patient, I think. A big thank you for your speakers and also for sharing their expertise and to all of you participants. And I hope this session will provide valuable insights that will help improve the, I think, patient outcome in AF management, I think. I look forward to the future discussion. Thank you for your sharing time, all of the speakers. Thank you very much.
Thank you.
Thank you. Thank you.
Thank you very much.
You.
Hi, Professor Lin. Thank you.
Thank you.
Thank you. Goodbye. Thank you.
Thank you. Goodbye.
Bye.
Thank you. Thank you.
Thank you very much.